This video is brought to you by Global Men's Wellness, your 24/7 AI health expert. No copays, waiting rooms, or awkward conversations. Just real answers whenever you need them. Visit globalmenswellness.com to try it free and get your own on-demand concierge-level wellness expert today. Welcome to the Global Men's Wellness. I'm Dr. Judson Brandeis, and I'm so glad you're here. When we think about urologic cancers, our minds often go to the prostate or the bladder. But there is another, less common cancer that lurks higher up in the body's plumbing system. It grows along the delicate lining of the ureters, the long tubes that carry urine from the kidneys, and within the kidney's own intricate drainage funnels. This cancer, known as upper tract urothelial carcinoma, or UTUC, is a rare and often aggressive disease. Because of its location deep within the body, it can be challenging to diagnose and even more challenging to treat. For decades, the standard approach was a radical surgery that removed the entire kidney and ureter. But today, guided by a new evidence-based understanding of the disease, we have entered an era of personalized care, one that carefully balances curing the cancer with the critical goal of preserving a patient's kidney function and long-term health. Today, we're going to explore this forgotten cancer of the urinary tract and the sophisticated new framework we use to manage it. So, what exactly is upper tract urothelial carcinoma? Imagine the lining of your urinary tract, from the kidneys, down the ureters, to the bladder, as a single continuous surface, almost like a waterproof ribbon. UTUC is a cancer of the exact same type of cells that cause bladder cancer, but it occurs on that ribbon before it reaches the bladder. It accounts for only about 5 to 10% of all urothelial cancers, making it far rarer than its bladder counterpart. However, its rarity doesn't make it less serious. At the time of diagnosis, a significant number of UTUC cases are already invasive and aggressive. The most common sign is blood in the urine, and the most common cause, just like with bladder cancer, is a history of smoking. It's also strongly associated with certain genetic conditions, like Lynch syndrome. The diagnosis and management of UTUC is a complex process, largely because of the tumor's location. It's not something we can easily see or access. The journey almost always begins with advanced imaging, typically a CT urogram, which uses contrast dye to highlight the entire urinary tract and can reveal a tumor or a suspicious thickening in the lining of the kidney or ureter. But an image alone isn't enough. To get a definitive diagnosis, a urologist must perform a procedure called a ureteroscopy. This involves passing a very thin, flexible scope with a camera on the end through the bladder and all the way up the ureter to directly visualize the tumor. During this procedure, we can take a small biopsy of the tissue. This biopsy is critical, as it tells us the tumor's grade, whether it is low grade or high grade, which is the most important factor in determining how aggressive the cancer is. Our approach to this challenging cancer has been revolutionized by the 2023 AUA and Society of Urologic Oncology guideline. This isn't just an update, it represents a fundamental shift in philosophy. The old model was a one-size-fits-all approach. If you had UTUC, you underwent a radical nephrorectomy, or RNU, which is the removal of the entire kidney, ureter, and a small cuff of the bladder. The new guideline is built on a proven, evidence-based principle of risk stratification. We now categorize patients into low-risk and high-risk groups based on the findings from their imaging and ureteroscopy biopsy. This stratification allows us to personalize treatment, offering less invasive, kidney-sparing options to low-risk patients while reserving more aggressive therapy for those with high-risk disease. Another major evidence-based change is the strong recommendation to offer cisplatin-based chemotherapy before surgery for patients with high-risk UTUC, as this has been shown to improve survival outcomes. Given the aggressive nature of UTUC, why isn't there more public awareness? The primary reason is its rarity. It is simply overshadowed by the much higher incidence of prostate, bladder, and even kidney parenchymal cancers. Furthermore, the diagnostic process itself is highly specialized and invasive, requiring a skilled urologist to perform a delicate ureteroscopy. This isn't a simple blood test or a routine scan. This lack of broad public recognition means patients might not understand the significance of symptoms like blood in the urine, potentially delaying diagnosis. The patient experience for UTUC varies dramatically based on their risk category. For a patient diagnosed with low-risk disease, The goal is to eradicate the cancer while preserving their kidney. This might involve an outpatient endoscopic procedure, where the tumor is ablated with a laser through the ureteroscope. In recent years, we've also seen the development of topical therapies, where a chemotherapy gel is instilled directly into the kidney's collecting system to treat the tumor. While kidney sparing, this approach requires a very intensive surveillance schedule, with repeat ureteroscopies every few months to ensure the cancer has not returned. For a patient with high-risk disease, the experience is more demanding. It often begins with several cycles of neoadjuvant chemotherapy, administered by a medical oncologist. This is followed by a major surgery, the radical nephroreterectomy, which is most often performed using a minimally invasive robotic approach. This requires a hospital stay and a significant recovery period, but it offers the best chance for a cure. This is the essence of personalized urologic care in the modern era. The treatment plan is no longer automatic. It is a carefully considered strategy based on a multitude of factors. For the patient with a small, low-grade, non-invasive tumor, low risk, we prioritize preserving the kidney. This is critically important, as losing a kidney can have a significant impact on long-term cardiovascular health and overall survival. For the patient with a large, high-grade tumor, high risk, our priority shifts to aggressive cancer control. Here, the personalized approach involves determining if the patient is a candidate for cisplatin-based chemotherapy before surgery. This shared decision-making process, involving the urologist, medical oncologist, and the patient, is central to the guideline. This risk-stratified approach has proven to be highly effective. For carefully selected patients with low-risk UTUC, kidney-sparing surgery offers excellent cancer control that is comparable to radical nephroreterectomy, but with the enormous benefit of preserving renal function. For patients with high-risk disease, radical nephroreterectomy provides a durable cure for the majority with localized cancer. And for those who are candidates, adding neoadjuvant chemotherapy before surgery has been shown to significantly improve survival rates, representing one of the important advances in the field. The future of UTUC management is focused on refining our ability to risk stratify patients and on improving our kidney-sparing techniques. Researchers are actively working to identify molecular and genetic markers that can more accurately predict a tumor's aggressiveness from a small biopsy sample or even from a urine test. This could help us select patients for kidney-sparing surgery with even greater confidence. We are also seeing advances in the development of novel topical therapies and drug delivery systems that can more effectively treat tumors within the upper tract while minimizing side effects. I do this work because tackling a rare and aggressive cancer like UTUC requires a thoughtful and multidisciplinary approach. The better way is not to simply offer every patient the most radical operation. The better way is to use our best diagnostic tools to understand the specific risk of each patient's cancer, and then to tailor the treatment to that risk. It's about having the courage and skill to be aggressive when the cancer demands it, and the wisdom and precision to be conservative when we can safely preserve a vital organ. By doing so, we give our patients the best possible chance not only to be cured of their cancer, but to live a long and healthy life with the best possible quality of life. Take control of your health anytime, anywhere. Visit globalmenswellness.com and start your free trial today. Get expert-level answers in seconds, not weeks, without the cost, the wait, or the awkward conversations. Real support on your terms. Visit globalmenswellness.com now.